Comprehensive Q&A on the surgical management of rectal cancer. Welcome to today's episode of the Everything Surgery podcast, where we dive deep into the surgical management of rectal cancer. In this podcast, we'll explore 100 essential questions and answers, spanning anatomy, staging, surgical techniques, neoadjuvant therapy, complications, and ongoing controversies. Pause video when you hear the word answer to attempt answer. Let's dive right in. Anatomy and pathophysiology. Question: how do we anatomically define the rectum? Answer: the rectum is 12-15 centimeters long, extending from the sacral promontory to the anal verge. It's divided into the upper, 12-15 centimeters, middle, 6-12 centimeters, and lower, 0-6 centimeters, sections. Question: what arteries supply blood to the rectum? Answer: the superior rectal artery, from the IMA, middle rectal, from the internal iliac, and inferior rectal, from the pudendal artery provide the blood supply. Question: what are the lymphatic drainage pathways for the rectum? Answer: the upper rectum drains along the superior rectal artery to the inferior mesenteric nodes, while the lower rectum drains to the internal iliac and inguinal nodes. Question: can you explain the mesorectum? Answer: the mesorectum is the perirectal fat enclosed by the mesorectal fascia, containing key lymph nodes. Question: what is the holy plane of Heald? Answer: it's the avascular plane between the mesorectal fascia and presacral fascia, which is crucial for total mesorectal excision. TME. Question: what's the controversy regarding the lateral ligaments? Answer: the existence and content are debated, but they may contain the middle rectal vessels and nerves. Aggressive division can risk nerve damage. Question: what is Waldeyer's fascia? Answer: this is a dense presacral fascia that must be sharply dissected during TME. Question: define the anorectal ring. Answer: it's formed by the puborectalis muscle and is a key landmark for sphincter preservation. Question: what significance does the dentate line have? Answer: it marks the mucocutaneous junction and acts as a watershed for vascular supply and innervation. Question: what are the rectal valves of Houston? Answer: these are transverse folds, typically 5-8 centimeters from the anal verge, with the middle valve serving as a landmark for the anterior peritoneal reflection. Diagnosis and staging. Question: what's considered the gold standard for rectal cancer diagnosis? Answer: colonoscopy with biopsy is the gold standard. Rigid proctoscopy is used for distal tumors. Question: why is MRI of the pelvis important? Answer: it's essential for local staging, determining TN status, circumferential resection margin involvement, and EMVI presence. Question: what does MRTRG refer to? Answer: it's the MRI tumor regression grade, assessed after neoadjuvant therapy. Question: define circumferential resection margin, CRM in rectal cancer. Answer: CRM stands for circumferential resection margin, with 1 mm denoting a higher risk of local recurrence. Question: what is EMVI? Answer: extramural venous invasion, a marker of poor prognosis. Question: how does TNM staging work in rectal cancer? Answer: it classifies tumors as T1, T4, nodes as N0, N2, and metastasis as M0, M1. Clinical, CTNM, and pathologic, YPTNM, staging are important post-neoadjuvant. Question: what is a clinical complete response? Answer: it's when no residual tumor is found on clinical exam or imaging, opening possibilities for non-operative management. Question: why is MSI testing relevant? Answer: it screens for Lynch syndrome. MSIH tumors respond differently to 5-FU. Question: what's the role of CEA in rectal cancer? Answer: it's not diagnostic, but serves as a preoperative baseline and for recurrence monitoring. Question: when is PET-CT indicated? Answer: for detecting distant metastases, not primary staging. Neoadjuvant therapy. Question: when do we use neoadjuvant chemoradiation? Answer: for T3/T4 or node-positive mid-low rectal cancer, typically 5-FU capecitabine with 45 to 50.4 gray radiation. Question: what is short-course radiotherapy? Answer: 5 fractions of 5 gray, with surgery soon after, often used for older or palliative patients. Question: define total neoadjuvant therapy, TNT. Answer: both chemotherapy and chemoradiation are given prior to surgery for better compliance and control. Question: what is the prospect trial? Answer. It evaluates selective use of neoadjuvant chemoradiation for mid-upper rectal cancer based on response to FOLFOX. Question. What do we mean by watch and wait? Answer. Non-operative management for patients with clinical complete response, requiring stringent follow-up protocols. Question. What are organ preservation options post-neoadjuvant chemoradiation? Answer. Local excision techniques like TEM or TAMIS for Y-page T0-1 disease. Question. Summarize the OPERA trial. Answer. It studies TNT followed by either watch and wait or local excision. Question. How long after neoadjuvant chemoradiation should surgery be performed? Answer. Typically 6-12 weeks, as longer intervals can increase pathologic complete response rates. Question. What is pathologic complete response? Answer. Pathologic complete response, Y-page T0N0, occurring in 15 to 20% of patients after neoadjuvant chemoradiation. Question. What about the RAPIDO trial? Answer. It supports short-course radiation plus chemotherapy before surgery for better distant control. Surgical techniques. Question. What is total mesorectal excision? TME? Answer. The gold standard for rectal cancer surgery, involving en-bloc resection of the mesorectum. Question. How is total mesorectal excision quality graded? Answer. As complete, nearly complete, or incomplete, which correlates with recurrence rates. Question. When is partial mesorectal excision appropriate? Answer. For upper rectal cancers, with a 5 cm distal margin. Question. Compare LAR and APR. Answer. Low anterior resection. LAR preserves the sphincter, while abdominoperineal resection, APR, results in a permanent colostomy. Question. What is intersphincteric APR? Answer. A sphincter-sparing variant with lower recurrence than standard APR. Question. Describe TATME. Answer. Transanal TME is used for low tumors but is controversial due to recent evidence of higher recurrence. Question. What's the advantage of robotic TME? Answer. Superior visualization in the narrow pelvis, with similar outcomes to laparoscopy. Question. When should lateral lymph node dissection be considered? Answer. For clinically positive lateral nodes, standard in Japan but debated elsewhere. Question. What is TEM or TAMIS? Answer. Transanal local excision for benign or early cancers. Question. What is Hartmann's procedure? Answer. Rectal resection with an end colostomy, often for palliation or high-risk cases. Complications. Question. What's the risk of anastomotic leak? Answer. About 5 to 15%, especially with low anastomosis or after neoadjuvant chemoradiation. Question. What is the ALF classification? Answer. A system for grading anastomotic leaks. AE. Question. How are anastomotic leaks typically managed? Answer. With diversion, drainage, and antibiotics. Question. What is pelvic sepsis? Answer. Infection arising from a leak, potentially necessitating washout or drainage. Question. Define low anterior resection syndrome, LARS. Answer. Symptoms include urgency, frequency, and incontinence after low resections. Question. What's the risk of sexual dysfunction? Answer. Approximately 30 to 50% due to nerve injury during surgery. Question. What is bladder dysfunction? Answer. Urinary retention from pelvic nerve injury. Question. Name common ostomy complications. Answer. Retraction, prolapse, and peristomal hernia. Question. What is presacral bleeding? Answer. Bleeding from basivertebral veins, requiring prompt control. Question. Discuss perineal wound complications. Answer. More common after APR, may require reconstructive flap surgery. Special scenarios. Question. How do we approach low rectal cancer? Answer. Neoadjuvant therapy followed by sphincter-preserving LAR or APR. Question. What is ultra-low anastomosis? Answer. A hand-sewn or stapled colonal anastomosis. Question. Why use a diverting ileostomy? Answer. It protects low anastomosis and is usually reversed after 3-6 months if no leaks occur. Question. What is the local recurrence risk after TME and neoadjuvant chemoradiation? Answer. Approximately 5 to 10%. Question. How should locally recurrent cancer be managed? Answer. With exenteration and reconstruction, if feasible. Question. Define oligometastatic disease. Answer. Limited metastases, often to liver or lung. Resection can result in 30 to 50% 5-year survival. Question. What is CRS-HIPEC? Answer. Cytoreductive surgery with hyperthermic intraperitoneal chemotherapy for select peritoneal cases. Question: how is obstructing rectal cancer managed? Answer: with stent or stoma, followed by neoadjuvant therapy and surgery. Question: how does pregnancy affect management? Answer: surgery is safe. Chemoradiation is usually delayed until after delivery. Question: what's a metachronous metastasis? Answer: a recurrence more than 6 months after initial resection. Controversies and advances. Question: is laparoscopic TME equivalent to open surgery? Answer: yes, per the Color 2 trial, though it's technically more challenging for low tumors. Question: what controversies exist around TME? Answer: higher recurrence rates were seen in some studies, possibly due to the learning curve. Question: is lateral lymph node dissection always necessary? Answer: still debated. Standard in Japan but not universally in the West. Question: what's the success rate for non-operative management? Answer: up to 50% of patients can avoid surgery long-term with strict follow-up. Question: how does immunotherapy fit for MSIH tumors? Answer: agents like pembrolizumab and nivolumab are being explored for neoadjuvant use. Question: what is ctDNA-guided therapy? Answer: an emerging approach for adjuvant therapy decisions. Question: compare robotic and laparoscopic surgery. Answer: robotic surgery offers better access in the pelvis, as shown in the Roller trial. Question: what's extended TME? Answer: an en-bloc resection including adjacent organs for T4B tumors. Question: is sentinel lymph node biopsy used? Answer: not standard practice in rectal, unlike colon cancer. Question: how is AI impacting rectal cancer care? Answer: by predicting therapeutic response and recurrence risk. Miscellaneous question: how does rectal cancer differ from anal cancer? Answer: rectal is typically adenocarcinoma and treated surgically. Anal is squamous cell, treated with chemoradiation. Question: what's the risk of Lynch syndrome? Answer: 50 to 80% lifetime risk, often presenting at a younger age. Question: and familial adenomatous polyposis, FAP? Answer: near 100% risk of cancer without colectomy. Question: how does neoadjuvant compare with adjuvant chemotherapy? Answer: neoadjuvant is often better tolerated. TNT is the preferred approach. Question: CAP-OX versus FOLFOX. What's the difference? Answer: CAP-OX is oral, with similar efficacy to FOLFOX. Question: what about rectal gysts? Answer: these are rare. Surgery is indicated if 2 centimeters, with imatinib as a medical therapy. Question: how are rectal neuroendocrine tumors managed? Answer: low-grade tumors undergo local excision. High-grade require aggressive therapy. Question: what does NCCN recommend for follow-up? Answer: CEA every 3-6 months, CT every 6-12 months, and periodic proctoscopy. Question: what's EROS protocol? Answer: early feeding, mobilization, and multimodal pain control for optimal recovery. Question: what is the future of rectal cancer surgery? Answer: trends are toward less invasive approaches, organ preservation, and personalized therapy. Thanks for tuning into this comprehensive rectal cancer Q&A. Be sure to subscribe for more in-depth medical discussions and surgical insights.